Good evening, ladies and gentlemen. Welcome you to one-day virtual conference on Meet the Oncology Experts Treatment Update 2025. I would like to welcome Mr. Abhishek Bansal, Consultant Medical and Hematology of Oncology SSBC Multiple Hospital at Faridabad. Mr. Abhishek Bansal, this session is sponsored by AstraZeneca. Over to you, sir.
I think you can call it doctor for your kind information.
Dr. Abhishek Bansal.
Yeah, it was kind of rude actually.
I am extremely sorry, sir. Extremely sorry.
So I hope you are doing it for the first time.
Uh, no, sir.
So better take care in this for future.
Sure, sir. Sorry, sir.
What about the slides? Can you put on the slides or what?
Sure, sir. I
Sure.
will share it from my side. Sir, is the screen visible?
Yeah, it's visible. So good evening everyone good evening everyone to audience who is present here. So my topic for today is exceptional response to osimertinib, EGFR mutated metastatic non-small cell lung cancer. Next slide, please. Coming to a case study, in October 2020, Mr. X, a 64-year-old gentleman, presented with coughing, progressive breathlessness, and severe backache. And he could not walk without support in the last 10 days. And he had giddiness since 5 to 6 days with weight loss of 5 kgs in last 1 month. And personal history of he was non-smoker. Next slide, please. So coming to the PET scan, there was a mass lesion in right upper lobe with hilar nodes, and there were multiple bony mets. Next slide, please. So biopsy was done from the lung mass, and it showed histopathology of adenocarcinoma lung, and it was IHC, it was TTF1 and APSIN A positive, negative for P40, suggesting adenocarcinoma. On molecular analysis, it turned out to be EGFR exon 19 mutation positive, and rest all molecular markers were negative, and PDL1 was negative. Next slide, please. So we did a MRI brain, and it showed multiple ring enhancing lesions in the cerebellum and cerebral hemisphere with significant perilesional vasogenic edema. Next slide, please. So final diagnosis of our case was non-small cell adenocarcinoma lung with exon 19 deletion with bone and brain mets. Next slide, please. So management of this case was local radiation therapy for metastasis plus EGFR TKS to target exon 19 deletion. Next slide, please. So coming to the discussion, how do we manage a patient with EGFR mutated non-small cell lung cancer? First, these are the various uh, graphs showing the first, second, and third generation TKI response and median PFS is, in the various with the various TKIs, and you can see that the along with the trials that gefitinib had 9.5 months of median PFS, erlotinib had 13.1 months of median PFS, afatinib had 11 months, and dacopatinib, which are the second generation, had 14.7 months, and finally the last third generation osimertinib, which was 18.9 months of median PFS was achieved. Next slide, please. So degree of CNS penetration of osimertinib demonstrated higher mouse brain concentration than other TKIs. So you can see among all this osimertinib, gefitinib, and afatinib, the highest in brain concentration and brain plasma ratio was for osimertinib in the mouse. Next slide, please. So this is the MRI, which is basically showing the regional distribution of osimertinib, and we can see the degree of CNS penetration of osimertinib. Next slide, please. So coming to the regional distribution and binding of osimertinib on PET parametric images showing total volume of distribution, you can see as in the patient 1 and same in the patient 2, as we start osimertinib from the day 1 and as we progress from day 2 and day 22, after 21 days of osimertinib, the osimertinib starts accumulating in the brain and as seen in the PET-3 images, suggesting that it has a good intracranial penetration. Next slide, please. So coming to the managing a patient with EGFR mutated non-small cell lung cancer and CNS metastasis, a newly diagnosed EGFR positive non-small cell lung cancer, and if it's brain mets, if it's symptomatic, then we do a local therapy. Otherwise, we start with upfront osimertinib. And if we have a progression on the first and second generation TKI, if we are using first or second generation, and we have brain progressive disease, then if symptomatic, then again we address with local therapy. And if there is no symptomatic, then we check for T790 mutation. And if uh, is positive, then we start with osimertinib. And if T790 mutation is negative, and if there is non-symptomatic CNS progressive disease, we address with the SRS or WBRT and continue the same TKI. And if the if there is no CNS and systematic, if the brain mets are not symptomatic, then if there is CNS and symptomatic progressive disease, basically T790 mutation, if positive, then we start with osimertinib, and if T790 mutation is negative, and we address the CNS by SRS and WBRT, followed by the chemotherapy covering the systematic progression. Next slide, please. So coming to this Kaplan-Meier curve showing the FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease status at study entry versus EGFR TKI competitor, the standard of care. And you can see with known CNS mets and without known CNS mets, osimertinib, the median PFS was 15.2 with known CNS mets versus the standard of care, which was 9.6. The hazard ratio was 0.47. The curves are separating. And without CNS metastasis, also the median PFS was in the osimertinib arm was 19.1 months and standard of care had 10.9 months. Hazard ratio was 0.46. Next slide, please. So coming to the discussion treatment, FLORA trial and the brain outcomes. These are all the trials which afatinib, dacomitinib, and osimertinib of the and you can see in the FLORA, the dacomitinib excluded the brain metastasis, and in the FLORA, there were baseline asymptomatic CNS mets and baseline asymptomatic uh, uh, were present, and we could see that median CNS PFS was 15.2 versus 9.6 as discussed in the earlier graph, and hazard ratio was 0.47. And dacomitinib arm excluded the brain mets, and basically in the afatinib it had some brain penetrability suggesting a response in the Lux Lung 36 trial in the baseline asymptomatic brain mets, that median CNS PFS was 8.2 versus 5.4 months versus the standard of care. And next slide, please. So for bone mets, in this case, we gave palliative radiotherapy to spine for backache with along with zoledronic acid. For brain met, the patient denied the brain RT and wanted to see later, and he was started on the first line TK osimertinib 80 mg per day in November 2020. Next slide, please. So follow-up PET scan, you can see that the right upper lobe encasing the right upper lobe bronchus changes. You can see This the mass is reduced from 4 into 3 into 3.4 centimeter, 2.2 into 2.1 into 2.7 centimeter, and the reduction in the hilar and the paratracheal nodes. This is a follow-up PET scan which was done in March 2021. Next slide, please. So coming to the effectiveness of TKIs in brain metastasis, you can see the efficacy of osimertinib and first generation EGFR TKIs in patients with brain mets. The osimertinib overall response rate was 66%, and compared to erlotinib or gefitinib arm, and the basically uh, we could see the basically evaluation for a response and the CNS full analysis. Next slide, please. This is the PET follow-up MRI brain which was shown, and you can see the MRI lesion in the MRI with the lesions which were present earlier in the cerebellum and which have all cleared up, and this is basically the lesions have all disappeared along with the edema which was present. Next slide, please. So complete resolution of brain lesions on MRI brain, no additional intervention needed. Next slide, please. This was in July 21. Next slide, please. So coming to the case reports on osimertinib and brain mets with non-small cell lung cancer, a 53-year-old patient relapsed while being on chemotherapy for stage 3A, and subsequent scans revealed pretracheal nodal hypermetabolism on repeat brain MRI. She was found to have multiple brain mets, including a big 3.1 centimeter inferior vermine metastasis with surrounding edema. And she was started on osimertinib uh, at 80 mg daily, and patient complained of ataxia versus worsening significant uh, in the following days and was scheduled for craniotomy and tumor resection the following week. But you can see as we started osimertinib, then on day 0, day 15, day 60, there is day 15, there is decrease in the size of lesion with resolution of symptoms along with complete resolution of lesion at day 60. Next slide, please. So coming to the case reports on osimertinib and brain mets in non-small cell lung cancer. So as you know, osimertinib has demonstrated efficacy in stable or asymptomatic CNS uh, EGFR mutated non-small cell lung cancer. Uh, that the efficacy of osimertinib, the optimal treatment combination of sequence has not been investigated. This 74-year-old woman diagnosed with T4N1 M1 stage 4 lung cancer with EGFR mutation, left upper lobe mass and multiple bilateral lung mets. Total of more than 20 asymptomatic brain mets were present. Osimertinib was administered and whole brain radiotherapy was deferred because she had no neurological symptoms. After 4 weeks, the multiple brain mets disappeared completely together with the response in the lung lesion. This case demonstrates the first-line treatment with osimertinib, which achieved complete remission of multiple brain mets comprising as many as 20 lesions without need for radiation therapy. So this is a new treatment approach for brain mets in EGFR mutated lung cancer. Next slide, please. So this is another study which demonstrated the efficacy in CNS mets. This was a phase 3 open label study of 48 patients with metastatic EGFR positive lung cancer who received osimertinib, and they were treated uh, naive or treated with previous TKI or T790 mutation positive, and we studied uh, overall response rates, and medium intracranial PFS was 11.8 months in the A arm, which was treatment naive, and the B it was 7.6, and C, which was negative, which was 6.3. So suggesting that osimertinib demonstrated high efficacy on brain mets, all trial arms displayed a significant decrease in the number and diameter of target lesion. So the osimertinib is effective for T790 mutation positive patients and negative lung adenocarcinoma patients with asymptomatic uh, brain mets. So it should be considered as a viable option for EGFR mutant patients with brain involvement regardless of the T790 mutation status. Next slide, please. So coming to the further follow-up scan, the November 2021 and the April 22, you can see a almost complete response is present. So next slide, please. So key takeaway points are radiotherapy for brain is not needed. Still, patient had complete resolution of brain mets and almost complete resolution of primary disease and nodes. No any adverse events were reported. Patient remained progression free even after 19 months of initiating the osimertinib. He is asymptomatic and fully active, goes for morning walks and yoga sessions, leads a normal life. The excellent response to osimertinib. Are such tumors different? We have any biomarker to predict such excellent response? Next slide, please. Thank you.
Um, Dr. Abhishek Bansal, thank you for your presentation. Next, I would like to invite Dr. Amit Vadola. Um, this session is sponsored by AstraZeneca. Dr. Amit Vadola is Associate Consultant at Max Super Specialty Hospital, Sharmal Bagh. Dr. Amit Vadola, the stage is yours.
Hi, thank you. Uh, Let me share my screen first. My slides are visible.
Yes, sir.
Uh, Very good evening to everyone. So I'll just discuss further. I'm not able to move my slide. Yeah. So what is the incidence of non-small cell lung cancer overall? So if you'll see, it's almost 85% of the patients are non-small cell lung cancer, while 15% of the lung cancer are small cell. So a big number of chunk is non-small cell lung cancer patients. And now, fortunately, almost like more than 50% patient, we have some, targetable medication available. So if you'll see, the most common targetable driver we have is EGFR, 17%, followed by G12C KRAS mutation. And now then after that, we have BRAF, MET, HER2, ELK, RET, ROS, and so on, different driver mutation for which we have, targetable medication available. So if we see the incidence of EGFR mutation, it actually varies across the world. And in Asia, it is the most prevalent in the Asia, or ranging up to 62%. And we also know that with previous studies that the EGFR mutation non-small cell lung cancer patient, they are actually more prone for brain metastasis. The brain metastasis can be different. It can be leptomeningeal metastasis. It can be the parenchymal disease. And as for we know that from the data and our clinical practice, the worst is leptomeningeal metastasis. It is more frequent with EGFR mutation. If we compare with the wild type of EGFR non-small cell lung cancer, it's like 9.4% versus 1.7%. And if you see that in the previous studies, like almost double patients of EGFR mutation positive carries the brain metastasis. And does site of metastasis affects quality of life? Yes, it does. If you see if the disease is gone to the brain, it is actually the single most affected site, which will implicate on your quality of life of the patient. So there's a rapid decline of the quality of life if the patient develop brain metastasis. That's why we are, much concerned about that. And we also know that if the patient is having a brain metastasis, they have shorter progression-free survival and lesser overall survival as well. So brain metastasis in EGFR mutation, non-small cell lung cancer, and the TKIs. So what we already know that brain is a sanctuary site. We know that the chemotherapy are very poor penetrating the blood-brain barrier. We know that some TKI can cross the blood-brain barrier. Up to 40% of the lung cancer, of the non-small cell lung cancer with EGFR mutation will develop brain metastasis. And that's why we need a medication which can cross the blood-brain barrier, which is very important. So this is the preclinical trials of osimertinib, which demonstrate that it can penetrate the blood-brain barrier and attain a very significant plasma concentration in the brain compared to other first and second generation of the TKI. And it reflected in later on the clinical trials as well. So we know that what is osimertinib? Osimertinib is a third generation TKI, which is having a very good blood-brain penetration. It acts irreversibly. It reversibly bind with exon 19 and L858R exon at 21, and it is effective on resistant mutation T790M. It prolonged the overall survival. It prolonged the PFS, and now we have a data of osimertinib with chemotherapy as well. We have increased our PFS from 9 months to 19 months alone with this TKI. And when we add chemotherapy, we know that it's almost 2.5 years, which was a dream a decade back. How does the efficacy of osimertinib, if we compare with the first generation TKI, how does it different compared to first generation TKI? So this was a FLORA. This was a landmark trial. We know that the third generation TKI was compared with the first generation of TKI that time, and we know that the data it showed the PFS benefit. Later on the overall survival benefit was shown by third generation TKI. So if we see the FLORA patient, there was 21% patient who were having CNS disease at present. And if you see, as I told you earlier, if the patient is having disease in the CNS, they do poor compared to other site of metastasis. It is also reflected in the FLORA. The median PFS for the overall population was around 19 months, while if you see for the brain metastatic site, it was 15 months. While on the competitor arm, where there was a first generation TKI, the PFS was around 9 months. Sorry, it was around 10 months. And for the whole brain, the patient who were having brain metastasis was around 9 months only. This was which I was talking about. For the entire population, the PFS was around 19 months. And for that time, standard of care was first or second generation TKI, it was around 10 months. But if the disease is in the CNS, we know that these patients do poor. So their PFS was around 15 months. And the standard of care PFS was around 9 months. But another important thing, the CNS progression events, the patient, if you see the patient who were not having CNS disease, osimertinib prevents the CNS relapse also, and that is really important. This was a CNS full set analysis. We have already discussed it. Osimertinib has OS advantage. At 24 months, it was 74 versus 59, while at 36 months, it was 54 versus 44%. That is a great number. And this intracranial CNS analysis, the median CNS PFS was not reached with the osimertinib, while it was 13 months with a standard of care. This was important. Like the CNS progression was seen in 20% of the in the patient in the osimertinib, while double of the patient was progressed in CNS disease on standard of care. This is the same thing almost. Yeah, this is another thing. So patient who were started on the this third generation TKI at 36 months, almost 28% patient were on the third generation TKI. Well, only 9% patient at 3 years were on the standard of care. This is an important number. So this was in the trial. We saw a tremendous response with the osimertinib, but what evidence we have in the real world? And I know that lots of people are now, doctors are practicing osimertinib, and we know that it does change the life of patient. So this was two case reports. The rapid intracranial response to osimertinib without radiation, as discussed by previous speaker also, that now we don't need radiation in EGFR mutation patient who are having brain metastasis, because osimertinib does miracle in those patients. So this was a case one. I'll just go with a brief summary. So the patient underwent surgery 9 years back, and then developed, after 7 years ago, developed the bilateral lung nodules. And on mutation analysis, exon 21 L858R was detected. That time it started on gefitinib. The PFS was 2 years, which is better than compared to the trial population. Then progressed on gefitinib, started on the cytotoxic chemotherapies, developed the brain metastasis, give radiation to the painful bony sites, and again progress, done the again rebiopsy, and it later on find to have T790M mutation. At 7th line of the chemotherapy, osimertinib was started. And that time, the patient PFS, the performance status was 3. And within 13 days, there was a remarkable response. And if you see in the lung lesion also, it starts shrinking from day, in this scan on day 5. So we know that osimertinib works on day 1. It start working on day 1. Another patient, we will see, yeah. So a 76-year-old gentleman, of heavy smoker. We usually don't see EGFR mutation on smoker. Underwent surgery 10 years back, had relapse, and exon 19 deletion was positive, and developed multiple bone metastases at recurrence. Started on gefitinib, had on gefitinib for almost 4.5 years. Then in between, afatinib was given. On progression, there was oral chemotherapy was tried. Later on rebiopsy, again T790M mutation was detected. At that time, patient performance status was 2, and osimertinib started on 5th line. In the previous one, it was 7th line, and in this patient, it was on 5th line. And on day 10 after administration of osimertinib, there's a remission of the single brain the brain lesions, and the X-ray started, improving. The patient symptomatically improved, and from the performance status 3, he became PS1. So there's a complete remission of brain lesion on day 10, and these patients didn't receive any radiation to the whole brain. Despite that, he had a very good response. Same on the lung. So as I told earlier also, osimertinib start working very rapidly, and the patients improve symptomatically very early. Again, another case report, the complete remission with osimertinib in the patient of EGFR mutation with first-line osimertinib. The previous 2 cases where we have given osimertinib about 7th line and 5th line, this was in the first line. And we know that even in the first line now, osimertinib works very well. Patient diagnosed with exon 19 stage 4 lung adenocarcinoma, having asymptomatic multiple brain metastasis, and osimertinib started as a first line whole brain RT. We didn't give her the whole brain RT in this patient, and the response was both intracranially and extracranially. Patient had a complete CNS response. So what are the recent guidelines and updates suggested? We know that the osimertinib, and osimertinib. So if the patient we detect any metastatic non-small cell lung cancer adenocarcinoma who is having EGFR 19 and 21 LATAR 5 ATAR mutation, the osimertinib is preferred one. And now now we have other options as well, but we are quite familiar with the osimertinib, amivantamab plus lazertinib. I don't know, maybe in the future, but it is very well tolerated, and we are much more familiar with the osimertinib now, and it does miracle to my patients. Thank you.
Thank you, Dr. Amit Barula, for your presentation. Next, Dr. Mir Hussain, medical oncologist, Sher Kashmir Institute of Medical Science, Srinagar. Dr. Mir Hussain.
Hello.
Yes, sir.
Yes. Yeah. Am I audible? So I want
Yes, sir,
to.
you are.
I'm trying to share my slides, but I am not able to share it.
Please open the
So
presentation.
yes.
So, can we share? If you want to, should I share the screens?
I'm trying to.
Yes,
Can you stop sharing of other screen? Like Dr.
sir,
Amit
please
was
open your
there.
presentation, sir.
So
Just,
it's
Yes.
you.
just open your presentation, sir. Already screen sharing, sir.
Your screen is visible, sir, but your
Okay.
presentation is not
Yeah.
visible.
One minute. Is it now?
Yes,
Now
sir,
it's visible,
visible.
sir.
Please make it
Yeah.
a
My
full screen,
presentation
sir.
is visible.
Yes,
Yes,
sir.
sir, it
Please
is.
make it a full
Yeah.
screen, sir.
Okay. Thank you. So thank you, AstraZeneca, for this evening meeting on lung cancer. So I think the initial two presenters talked about the role of osimertinib in the management of lung cancer. Now
Sir,
we will
can you
continue.
please make it a full screen?
Yeah.
Thank you.
Yeah. Is it okay?
Yes, sir,
Yeah.
please.
So is it visible?
Yes,
Hello?
sir, it is.
Yes, sir.
Yes,
Yeah.
sir, it is.
Uh, So we will see how to optimize the treatment in the management of advanced EGFR mutated lung cancer. So we know that this is an important event in the pathogenesis and the progression of lung cancer, especially the non-small cell subtype, which is the commonest subtype in the lung cancer. And these EGFR mutations, they act as a drivers in the progression of the lung cancer in the downstream regulation of various oncogenic events. So roughly around 20 to 40% of incidence of this EGFR mutation positivity is seen in various parts of the world, more common in the Asians compared to the non-Asians. Here in India, we see it is around 20 to 23%. And if you look at the subtypes, we have these mutations are seen at exon 12 to 21, at 18, 19, 20. But commonly we see which are very much clinical relevance are 18, 19, 20, and 21. And among them, we see the commonly which are the druggable mutations are exon 19 and 21. But we have these EGFR TKIs which have some activity against the exon 18 and exon 21. So exon 19 is seen in more than half of the cases, and rest of these, like we have exon 20 in around 15%, exon 21 and 26%, and then the less percentage of exon 18 and exon 12. So if you look at for last 20 years, there has been a lot of development in the development of various tyrosine kinase inhibitors to block this mutation event in the pathogenesis of non-small cell lung cancer, and we have the first generation, second generation, and now we have third generation tyrosine kinase inhibitors. Among the first generations, we had the gefitinib and erlotinib. They were the first generation, mostly the reversible uh, blockers of the this EGFR tyrosine kinase activity, and they were very much inactive if somebody has a T790M mutation. Then the second generation is we have where the afatinib and dacometinib, they block besides EGFR other these ARB pathways like HER2, 3, 4. They had some irreversible uh, covalent binding with these EGFR TKIs and lead to a better activity compared to the first generation. But they again were not effective against the T790M. And now we are in the third generation TKIs where we have the osimertinib, a very wonderful drug, which is very specific about these EGFR uh, mutations, and it is again has an irreversible binding with these mutated EGFR tyrosine kinases, and has very this is different from the first and second generation in that it is very active against the EGFR T790M mutations, which is definitely a very difficult to manage with the first second generation TKIs and even with the chemotherapy regimens. So it is not, yeah. So osimertinib, we know is now a standard of care, first line standard of care in the EGFR mutated advanced non-small cell lung cancer. So the data for its efficacy came from this very important phase 3 trial, which is very famous Flora trial, which was a phase 3 trial where they looked at the efficacy of osimertinib versus the standard of care available TKIs, that is gefitinib and erlotinib, in the management of locally advanced or metastatic EGFR mutated non-small cell lung cancer. So if you look at the various these first, second, and third generation TKIs, if you look at some of the important characteristics, like we see the first generation, they usually act on the EGFR sensitizing mutation is 1921 commonly. Second generation again had effect in these 1921 and some effect in the 20. Third generation has again effectivity in these 1920 common 19 and 21, and also again as T790M, which is the resistant mutation, maybe de novo, and mostly they occur after the treatment with first or second generation TKIs. This first generation was a reversible inhibitor, second and third generation they are irreversible. So if you look at the important clinical effect is in the CNS, where we see that very minimal or almost negligible CNS penetration of first and second generation, but osimertinib has a very good CNS penetration. There is some structural difference between these first, second, and third generation TKIs. So if you look at this graph here, we see that this picture that besides the EGFR tyrosine kinase mutation is this osimertinib also acts against the T790M and has a very good CNS penetration, which has been documented in various human and preclinical models. So this coming to the Flora phase 3 trial, this was phase 3 double-blind trial where we compared the osimertinib with the standard of care this TKIs, that was gefitinib and erlotinib. The key inclusion criteria in the trial was patient is more than 18 years, a good performance, those who have deletion 19 or 21 point mutation, have not received any prior systemic chemotherapy or tyrosine kinase inhibitors, they had a stable CNS disease. Then some stratification factors were whether it was exon 19 or 21 abnormality, a race, whether they were Asian or non-Asian. So osimertinib was given at 80 milligram, and versus the standard of care gefitinib and erlotinib, they were given till there was an objective progression of disease, but they were at intervals. Both arms were assessed at every 6 weeks, and the RECIST 1.1 criteria was used for the response. But in the trial, in this trial, in the control arm, which was the standard of care TKI, there was crossover was allowed if during the treatment there was a progression which was documented or there was a T790M mutation. So crossover to osimertinib was allowed. The primary endpoint was the PFS, and then the secondary endpoint is to have objective response rate, is duration of response, disease control rate, the depth of response, and of course they looked at the overall survival as well. Most of these metastatic disease, the most of the trials, their primary endpoint or the secondary endpoint are usually the PFS, but OS is not seen in most of the trials if the PFS is not that extraordinary. But here they looked at the OS as well, and the patient reported outcomes and the safety. So what was this? If you look at this graph, there is a wide difference between the two arms, where the geftinib erlotinib versus the osimertinib. If you look at the upper one, that is the median PFS in the osimertinib arm versus the standard of care geftinib or erlotinib, there was almost double, near double PFS benefit was 18.9 months versus 10.2 months, with hazard ratio was 0.46, and it was statistically significant that this PFS measured that the direct benefit of drug is there very much, and this trial was very much powered to look at the PFS. And if they looked uh, at clinical groups, various clinical parameters, if you look at the PFS, it was more. This was seen that this osimertinib worked better in women compared to men. It was slightly better in the non-Asians compared to Asians, because this is slightly paradoxical because we have more EGFR mutations in the Asians than in the patient who had a very good PFS, who had a very good PS. The PFS was better, and those who have EGFR exon 19 deletions, their PFS was better. Rest, it was almost similar between the various subgroups. And then coming to the overall survival, if you look at this graph, again, the probability of overall survival was better in the arm which received the osimertinib. If you look at the median OS, that was almost 38.6 months compared to the comparator arm, it was 31.8 months, almost 7 months median OS advantage. The hazard ratio was 0.799 and p-value was not significant, but they looked at more patients were alive in the subsequent years after the first year and second year. If you look at the first year, it was the difference was around 6%. At 2 years, the difference was almost 15%, and this maintained around 10% at 3 years. And median OS at more than 3 years. Osimertinib patients who received osimertinib were more likely to be alive at 2 and 3 year landmark, which is quite unusual in a metastatic lung cancer. And in first time an EGFR TKI has been shown to translate a good PFS to a significant OS benefit. Yeah, so yeah, so what was very encouraging that over the subsequent years, most of the patients in the osimertinib arm were able to continue with the osimertinib, and their disease was very much controlled. If you look at this graph here, look at the 3 years, almost more than 3 times patients in the geftinib versus erlotinib arm compared to the osimertinib arm, around 28% compared to the 9% were continuing, and they had a very good disease control. So around 28% of patients were still receiving osimertinib at 3 years, which was 3 times more in patients in the comparator arm, which was just 9%. And there was, even at the cutoff, around 22% versus 5% of patients were still continuing with the treatment. So this was the time to the, then another beautiful outcome was that the need for the first subsequent treatment was lower in the arm which received the osimertinib compared to the standard of care geftinib or erlotinib. If you look at the need for the first subsequent therapy for those who received osimertinib, this was seen almost at a median of 25.5 months, almost more than 2 years, compared to the comparator arm which received geftinib or erlotinib. The need for giving the first subsequent therapy was seen just at the completion of 1 year. So this was another advantage of using this upfront osimertinib compared to the geftinib or erlotinib. If you look at the osimertinib efficacy with PFS and OS in the various clinical subgroups, PFS, we discussed that the benefit was seen in all the groups, but it was more in the women, in the patients who were younger, less than 65 years, those who were non-Asians, those who had a very good PFS, and those who were exon 19. And this was seen almost, this was reflected in the OS as well, that OS was better in OS was seen almost similar between the two arms, but those who were less than 65 years, their OS was slightly better in non-Asians and in those who had a good PFS and those who have EGFR exon 19 deletion. So this osimertinib's PFS benefit was clearly maintained consistently across all subgroups, demonstrating its superior benefit across all populations, including by race and across the different mutation subtypes, which is important as we discuss in the OS as well. All OS subgroups showed a positive benefit in favor of osimertinib, although this the effect varied between the different parameters. This is consistent with the PFS data in which all subgroups they favored the osimertinib. So why we focus that osimertinib should be given upfront in the management of advanced EGFR mutated NSCLC. So rather than waiting to give it a subsequent treatment, our focus should be to give it an upfront if the patient has a good affordability. So if you look at that, we know that once we give a first line treatment with either any geftinib, erlotinib, or any other first or second generation TKI, we know that roughly 30% of patients may need a second line therapy in the 1 or subsequent period of the follow-up. But almost among them, almost more than half are denied this second line treatment because at that time they may have some progression of disease, their PS may be poor, we are not able to do biopsy. So this is a very important if we give in upfront compared to give in the second line. So this is showing an example where we have 10 EGFR mutated patients who were started on the standard of care, geftinib, erlotinib, or afatinib. Among them, if you take 10 patients, 2 patients may die during the first line, or they receive only a palliative care upon progression. We could not do the T790M mutation. Then if you go to the subsequently, among those 8 patients, again, we see that we may lose 2 more patients. They may not be eligible for tissue biopsy, or we get a tissue biopsy which is insufficient, or we get the tissue sample which is very small, or we get a false negative if we do from the liquid biopsy. And then among another 5 patients, again, we may have half maybe T790M negative, where in the another 50% we may be able to give osimertinib. So there are various trials which have shown that somewhere between 60 to 80% of patients where we get a T790M test results, we may have to consider whether the test is valid or whether the biopsy is sufficient. And sometimes plasma testing may reveal a negative result. If you look at various these trials done, where we see that around in one of the trials by Akamatsu in 2017, around roughly 80% of patients who were screened for the AURA3 trial, they had a valid EGFR mutation test result, whereas another 20% we could not get it. Another trial where a biopsy was not possible in 20% of patients, or the sample was too small to do this EGFR T790M in around 25% of patients. In another study by Yon H.J. et al. Showed that approximately 60% of rebiopsy specimens, they were suitable for molecular analysis and not the 40%. And then the Ursula M.E. et al. Showed that around 70% of patients who consented to biopsy, they were tested for T790M, and another 30% they didn't. So this is how we see that the crossover and subsequent therapies for the FLORA experimental RM, if you take 100%, around 78% may discontinue the treatment. They may not, among them 31% will not go for the second line subsequent therapy, and another 48% the second line subsequent therapy may be the chemotherapy 68%, any other TKI other than the osimertinib 29%, other forms of treatment in 3%, and those 31% of patients in the experimental arm, they could not receive the second line therapy. And another this showing that in another 100% of patients where we had around 95% discontinued, those 30% of patients in the EGFR TKI arm, they could not receive the second line therapy, and in the another 60%, they may receive second line therapy in the form of, they may receive osimertinib in around 47%, around 53 will not receive, and in those 22% receive chemotherapy or any other cytotoxic, any other TKI which is not osimertinib, other forms of treatment. So here again, we could interpret that around 31% of all patients in the EGFR TKI arm, they may receive the second line osimertinib. So this is the various data we showed. Approximately one third of patients may receive a second line therapy in various phase 3 clinical trials. Here, if you look at the IPAS trial at the geftinib era, around after progression of geftinib, 75% could receive another form of treatment. Then another IFM trial, again a geftinib, here 49% received the subsequent second line therapy. Another geftinib, it was geftinib arm, it was around 72% and 88%. Then in the erlotinib, various trials, they have shown that around 63 to 68% could receive the second line therapy. And if you look at the CTON G0901 trial, it was comparison between geftinib and erlotinib, somewhere between 42 to 54% received subsequent second line therapy. If you look at the Lux Lung 3 trial, the afatinib arm, around 71% received the second line therapy after progression on afatinib. Lux Lung 6 was around 59%, and at Lux Lung 7, where we had a comparison between afatinib and geftinib, around 72 to 76% received. And in Flora, we see that those who received osimertinib after around 48% could receive the subsequent line of therapy, and in the geftinib erlotinib arm, in this, which was the comparator arm, 65% could receive the second line therapy, which was even the osimertinib crossover. So in the real world, this has been proven that if you give osimertinib, give it upfront compared to giving it the second line, because we deny the treatment to around one third of the patients. So this was a retrospective study of 140 patients from Germany, which identified their treatment patterns among 140, 130 were treated with first line EGFR TKI, and 10 patients received upfront chemotherapy. And among these 130 patients, 112 patients were candidates for second line therapy. And in second line therapy, 30% of these patients did not receive second line therapy. Reasons may be a patient's refusal, they had a poor PS, their quality of life has deteriorated with the treatment, and they may have a frequent chain of disease, or they had fast progression and death. And 104 patients in the study were treated after accessibility to third generation TKI, and across all lines of therapy, only around 29% were treated with a third generation TKI after accessibility. So this is the real world data across the various places. Like if you look in the US, second line therapy has been shown to be received by with the osimertinib from 9 to 17%. In the Europe, in the Germany, especially around 23 to 25%, and in the Eastern Asia, around somewhere between 19 to 36% could receive the osimertinib in the second line setting. So this is again head-to-head clinical trials which are consistent with this real-world data, that not all patients receive osimertinib in the second line. If you look at these trials where this was the Archer 1050 second line treatment, is those who received the decomitinib versus geftinib second line, it was not more than 40 to 50%. And in the Flora, we could see that those who received osimertinib, they're around 48% received the second line treatment. So treatment sequencing in advanced, we should not focus that we'll give a sequential therapy. Wherever we have to see, we have to try to choose osimertinib in the first line, and we don't have to see the survival with the first line versus second line osimertinib. Whatever the result is, they are best if you use it at the first line. So this was in the first line with a PFS advantage of 18.9 months. And if you use in the second line after the first line, it may be around 10.1 months only. So the reason is could be then progression, maybe a T790M, or we could not do it. Our patient is not eligible to receive the second line therapy. So what message we could draw from this Flora is that osimertinib is the only EGFR TKI which has demonstrated clinically and significantly statistically significant improvement in the OS. This was the first trial to demonstrate how an EGFR TKI has translated PFS into an OS benefit. This osimertinib improved OS compared to the first line EGFR TKIs, especially those who had EGFR T790 NSCLC, where we could not use any first generation TKI. And this was the only EGFR TKI which reported a very good intracranial activity. And at a dose of 80 milligram, it is very well tolerated. Adverse effects are not that high, and sequencing cannot be considered the best strategy, as almost 70% patients they may not be eligible to receive the osimertinib in the second line. Though this data confirms that osimertinib as the first line standard of care in metastatic EGFR mutated non-small cell lung cancer. So these are the NCCN guidelines, where again it has been shown that those who are exon 19 deletion or exon 18 mutations and they have not received any EGFR upfront, we have to use preferably osimertinib, and if not, then we can give them chemotherapy, erlotinib, afatinib, geftinib, dacomitinib, or erlotinib, ramucirumab, erlotinib, bevacizumab, and then follow up for any progression, and then we may change. And if we discover the mutation once we have started a planned chemotherapy, so there are nowadays, earlier we had to complete the chemotherapy and then switch to these TKIs, but nowadays we may interrupt the treatment and go to these TKIs, especially the osimertinib, and if not, then we may give erlotinib, geftinib, afatinib, or any other TKI, or combination of erlotinib, bevacizumab, or erlotinib, ramucirumab. Thank you. Thank you.
Thank you, Dr. Mir Hussain, for your presentation.
Yes.
Next, Dr. Javed Muzammil. He is medical oncologist at Super Specialty Hospital, Srinagar. Dr. Javed Muzammil, the stage is yours.
Thank you very much, AstraZeneca, for giving me opportunity today, and thank you, Horizons, for organizing such a meet. Can I share my screen because it is still saying that?
Yes, you can, sir.
Okay, fine.
Coming to the baseline characteristics, the median age was 64, 55 years. They are PS 40% of the patients.
You can see my screen now?
Yes, sir. It's visible.
In a slide share mode? Yes.
Yes, sir, it is visible.
Thank you very much. I think it has been already discussed about how to use osimertinib in our day-to-day practice, and I'll be just highlighting the evidences, which trials and what are the advantages, and rest previous speakers and Dr. Mir Hussain has already highlighted these things. So a bit about the lung cancer epidemiology. We know it's one of the most common cancer, as you can see, that second most common cancer diagnosed in males and third in females, and number one in the cancer mortality in the men. So if we see relative survivals of the lung cancers, we have to look on the stage and when we diagnose these patients. Most of our patients are diagnosed, that is 66% of patients are diagnosed in stage 4 disease, and 29% of patients are diagnosed in stage 3 disease, and in stage 1, stage 2, you see almost nil. And depends upon the stage of diagnosis, you can see the survivals also. And here you can see that patients who have stage 4B disease, the 5S survival is not seen. But this was based on the previous classification. And now in the era of the TKIs, you see 5-year survivals as well. So the higher you go, the lesser will be the survivals. So now we see that since the NGS came and the biomarkers have come up, and most of the times we see 50% of the patients will have biomarker positive disease, and all are not targetable, but 20 to 30% are targetable. We have anti-EGFR molecules available, anti-ALK, anti-ROS, and anti-MET available, and KRAS inhibitors as well. but most of the times we use the EGFR inhibitors, ALK or ROS inhibitors, and sometimes KRAS actually not available in India, and the cost is very high, which are beyond the affordability of the common patients. So these biomarkers can be predictive and can be prognostic. Predictive markers, they will indicate which therapy you will use. Prognostic markers are independent of the treatment you patient receives. That will tell you about the what survivals we will be having with each molecule. Since the advent of these biomarker studies, then we see the different investigations came up in the market, and you can use ASC, FISH, or PCR based analysis. Nowadays, we don't use all these things. We go for the NGS and broad based NGS at the beginning, and you will come up with all these molecular abnormalities which a patient will harbor. And sometimes you can see two mutations together, and you can have two drivers together. And coming up to the EGFR driver mutation, which we are discussing today, if you can segregate, you can see the EGFR mutations in exon 18, exon 19, exon 20, and exon 21. And the sensitive mutations we see are in the exon 19 and exon 21. But exon 20 also has some sensitive mutations which are sensitive to these newer drugs like osimertinib. And there are some rare mutations which are sensitive to afatinib, that is in exon 18. So, how common are these EGFR mutations in lung cancer? And we can see that in Asians there is more. We see more EGFR mutations, around 30 to 40% in most of the studies. But in Caucasians, we see half of them having the EGFR mutation. Do we have EGFR mutations, similar incidence, similar quantum in across all the stages? Yes, there is slight difference, but most of the times, if you go from stage 1 to stage 4, you are seeing a same tone of EGFR mutations, whether in Asia, whether in US, or whether in Europe. And here now the recommendation, we were earlier saying that in stage 4 only you go for EGFR mutations and see the drivers and then give the targetable agents. But here now, since now the studies have gone into the adjuvant stage as well. So here you have to check the EGFR status. In fact, ALK status also in adjuvant setting also, because you have now Adura trial where you can give in adjuvant setting osimertinib, and that has changed the whole scenario of the treatment. Now, how osimertinib is different from that of the rest of the TKIs, first generation, second generation. Here, it is a third generation. Osimertinib is a third generation molecule. It is irreversible on this EGFR molecule. It has an activity in CNS, and it crosses the intact blood-brain barrier as well. And you can select this molecule for EGFR mutant as well as EGFR T790, which is an acquired mutation, which is we see resistance mutation, which come up in 50% of patients who harbors the EGFR mutation. So it has a lower activity against the wild type. So, what are the evidences that we see in studies for use of these molecules? This has been discussed partly. So, the FLORA trial, that was the first trial that was done with this molecule, and randomized double-blind phase 3 trial, who assesses the safety and efficacy of the osimertinib versus standard of care, which was the first generation TKIs in locally advanced or metastatic EGFR mutant non-small cell lung cancer. So the inclusion criteria were same, that good performers and sensitive mutations like exon 19 mutation or exon 21, no prior anti-EGFR molecules, and stable CNS metastasis was included in the trial, and they stratified the disease, this analysis into exon 19 deletion versus exon 21 mutation, or Asian versus non-Asians. So osimertinib was given as 80 milligrams and was continued till progression, or the another arm was first generation TK like geftinib or erlotinib, and the crossover was allowed if patients were progressing in the geftinib or erlotinib arm. They were allowed to cross over to osimertinib. The primary endpoint was progression-free survival, And the secondary endpoint was the overall survival, objective response rate, duration of response. If you look at the patient disposition in Flora trial, you can see it was equally matched in osimertinib as well as the standard of care. And here, two-thirds of the patients were females, two-thirds of the patients were non-smokers, and yeah, one another important two-thirds of the patients had EGFR mutation in 19 exon. Now coming to the primary endpoint, which was the progression-free survival, and here you can see a median progression-free survival was around 19 months versus 10 months. So there was a 9-month improvement in the progression-free survival with osimertinib versus first-generation TKIs with a hazard ratio of 0.46. That means 54% reduction in the progression. And if you look here, this from this Kaplan-Meier curve, you can see the curves are moving apart. And so this has become the osimertinib reduces the risk of progression by 54%. And if you look at the uh, PFS subgroup analysis, there are all subgroups which got benefited with this osimertinib, and you can see whether what was the type of mutation, whether it was an DEL19, whether it was L858R, whether it was a CNS metastasis, there was no CNS metastasis. You can see the delta is away from the unity, so it improves progression-free survival in all subgroups. And now coming to the objective response, that's not much difference between the first generation TKIs versus osimertinib. So objective response rates are almost similar. But one important thing is that progressive disease that was not that was very uncommon in osimertinib. You can see one progressive disease versus 5 progressive disease. And but the importance is the duration of response. The duration of response was more. It was double. That is 17.2 months versus 8.5 months with the first generation. So that was an important thing. Now coming to the overall survival, if you look at all those studies so far, smart in these TKIs are not giving improvement in the overall survival. It is the progression-free survival benefit, improvement in the quality of life. But here, the first time the TKI is giving overall survival benefit that's coming with the osimertinib. And you can see here the overall survival benefit is median overall survival is here 38.6 versus 31.8. So around 8 to 9 months of overall survival benefit with a hazard ratio of 0.799. So it is the first time the overall survival benefit that was significant. And the adverse events almost they are matching, but lesser rash. And I have not seen clinically that much of the area which is seen in this Flora trial, that's 60%. But it's very much tolerable drug, very much tolerable than first generation TKIs. So summarizing the Flora data, that osimertinib resulted in highly statistically significant and clinically meaningful overall improvement in progression-free survival, then overall survival as well, with a significant meaningful improvement in the PFS over the standard as far as the CNS is concerned, with a hazard ratio of 0.48. Final analysis of OS resulted in the showing the promising survival trend towards the osimertinib versus standard of care. So osimertinib is now the standard of care of first line in patients who have EGFR mutation positive. Looking at the CNS, if you look at the patients who had the CNS metastasis at the beginning, the hazard ratio has been 0.48 as far as the progression-free survival is concerned. So again, the median PFS in CNS is 15 months versus 9.6 months. And those patients who had no CNS disease at the beginning, still the hazard ratio 0.46, again 19 months versus 10.9. So whether patient is having CNS metastasis or not, osimertinib has a very good PFS in the CNS as well. And you can see now here also the curves, they are too much separating, having 50% reduction, almost 50% reduction in the progression in the CNS, and you can see in the CNS activity with the osimertinib. If you compare with this, has been shown by Dr. Amir Hossain earlier, that if you compare with dacomitinib, if you compare with the other drugs as well, you can see Archer that the start of this showing the differences from the first generation TKI, it's at least at 6 months. You have to wait for that dacometinib to act, but you see the osimertinib starts within 1 to 2 months. So within 1 month, you see the difference. And again, overall survival difference is not seen with the any drug except osimertinib. It was not with the dacometinib as well. So looking at now the with the afatinib, which is another second generation TKIs, and here you can see the median PFS was not different from the first generation, but yes, there was here you can see at 24 months there was some difference, but here in osimertinib median PFS is 18.9 months, and there was insufficient events to determine osimertinib OS of the afatinib at the time of analysis. So this is how afatinib lung trial, you can see there is no overall survival differences. And the toxicity is really, really different. If you look at the Flora trial, toxicity is really different. It's very well tolerable drug than afatinib dacometinib.
Can someone introduce the
Flora study was also very important as far as the sequencing was concerned. Someone tries to give the osimertinib in the second line, but as you have seen that from previous speaker, that 30% of patients won't receive the drug. So you are losing that benefit. So in that context, you are not going to improve the overall survival in such kind of patients. So again, and we don't know which patients will get the this T790 mutation. So that's here the 30% don't get the drug. So 47% of patients will develop the acquired mutation. So in those patients, what to do? So there you can give osimertinib, but it is better to give osimertinib in the first line to decrease the chance of getting this T790 mutation.
Yes.
So Flora 2, this was another phase 3 trial where the osimertinib with platinum-based chemotherapy was used in a state of only osimertinib drug. So here the comparison between osimertinib with 4 cycles of platinum-based chemotherapy followed by osimertinib versus osimertinib alone. So the patient distribution inclusion criteria, they were similar to the Flora trial. So you can see here, if you add in a fit patient platinum-based chemotherapy and give osimertinib to them, and you can see there is further improvement in the prog. So it is ahead one step to Flora trial. So Flora 2, it actually tries to see the benefit of chemotherapy with osimertinib. So you can see here for 24-month, 57% progression-free survival versus 41-month without chemotherapy. So here you can see the hazard ratio has been 0.62. So this is one thing. Now, if a patient has a brain metastasis, hazard ratio is 0.47 once you add chemotherapy. So it is 24.9 month versus 13.8. So you are trying to add. So it was seen both with independent central review progression-free survival versus investigator-assessed progression-free survival. So you are trying to add. So the conclusions of the Flora 2 was that investigator assessed median PFS 25 months versus 16.7. So there's 8.8-month improvement. And this we don't know about the OS data yet. It will take some time once it will mature. So this is here the NCCN guidelines in the sensitivity mutation. The osimertinib has been given as a preferred recommendation as a first line. So it arrested all category 1. So osimertinib, that is Flora 2 treatment. That's osimertinib with chemo. It is uh, another this is not preferred, but it's a category 1. The rest are all the category 1 options. So concluding this, that for the first time, the evolution of the EGFR osimertinib translated PFS into a significant benefit. Osimertinib has a median PFS of 18.9 months and median OS of 38.6 months, which is significantly higher than the first and second generation TKI. Osimertinib has shown efficacy in the CNS metastasis. So fewer CNS progression events were observed with osimertinib. So fewer or less adverse events gives osimertinib a better safety profile than there will be other TKI. Osimertinib is a new standard of care for first-line therapy in patients with EGFR advanced non-small cell lung cancer. Thank you very much for patient hearing.
What we are doing routinely in all the
Thank you,
sir.
Dr.
Thank you, Dr. David Mazamil. Thank you, everyone, for joining for today's Meet the Expert. And thanks to my colleague Swarangi and Drew. Thank you, everyone. Good night, everyone. Thank you, support team. Dhruv, do we have any other speaker?
No, ma'am.
Okay. Thank you, sir. Thank you, Dr. Javed Muzammil, Dr. Mir Hossain, Dr. Abhishek Bansal, and Dr. Amit. Thank you, everyone. Good night, everyone.
Thank you.